This is podcast on the Geriatric Summative Aging PowerPoint. We're going to continue with alteration and urinary elimination. And what problems do the elderly have? What are common effects of aging related to bladder elimination? And what nursing interventions or education could a nurse provide a client who has urinary incontinence? So remember, there's that big chart in the book about common symptoms of urinary alterations and different types of incontinence, so you'll want to review that. And the common effects of aging related to bladder elimination would be increased risk for UTI and also with incontinence, just as a result of all the changes in aging. They are on a lot of medications that can affect their urinary elimination. They have altered sphincter. Remember, the sphincter is a muscle, so they have less muscle tone throughout the body. They have, men have enlarged prostate. Women can get a cystocele and rectocele, which is basically a collapse of the urinary bladder or the rectum into the vagina, and it basically takes on a reverse shape than it should have. Uterine prolapse, again meaning the uterus has fallen from where it originally was, and also diminished kidney function, definitely areas. When we look at nursing interventions, we want to make sure that we're doing focused assessment and really reviewing medications, especially if they're taking medications for their incontinence or overactive bladder. Is it working, and do they need to continue to be on there? So you want to take a look at that too. Making sure you're recording intake and output, providing assistance to the bathroom or assistive devices in the bathroom, providing products to assist with any bladder leakage or dribbling. Definitely, most people are going to want some privacy when that is available. You could do mini teaching with group, making sure that you are talking about safety, getting back and forth to the bathroom, that if they're on a diuretic, that they still need to drink even though they don't want to go to the bathroom as often. Obviously, you're going to report any problems to a physician. Making sure part of that focused assessment is looking at labs. The next topic is alterations in bowel elimination. So, common problem in people who are aging is constipation, and again, it's part of that slowing of the metabolism and loss of muscle tone. We see that as an effect of aging. What signs and symptoms of constipation? What nursing interventions or education could a nurse provide to help prevent constipation or fecal impaction? So we know that when people have less mobility overall, that decreases their bowel mobility. So sometimes activity and movement can increase bowel motility and decrease constipation. People who are on pain medication, opioid pain medications, that can affect bowel elimination and poor nutrition. Signs and symptoms of constipation are abdominal pain. We might even see some diarrhea that squeezes through because the bowels it's so blockaded that the bowels are spasming to get some through. We might see decreased bowel sounds as well in our assessment. So we want to make sure that we are providing extra fluids, extra fiber, encouraging activity where possible, that we are keeping a record of bowel elimination, and I know that you all did that in clinical. Offer with combination with the care provider, stool softeners, laxatives as needed. We might do an education on good nutrition, activities, and medications with a group of the elderly or one-on-one, reporting any problems to the physician, and knowing that if we might need to do a digital exam for fecal impaction or give enemas, things like that, to eliminate those. Some diet remedies we could suggest prior to medication might be just some hot water. Sometimes that hot water increases bowel motility, and prunes or prune juice, and that works very well when it's heated, especially. Again, with the fiber and roughage, encouraging fluid intake of at least 2.5 liters per day. Again, exercise program, and ignoring the individual, not to ignore the urge to go to the bathroom. A lot of people will do that, and we may need to do a manual removal of impacted stool. When we look at alterations in vision and hearing, we want to look at, we'll talk about vision first, and we see a lot of vision deficit with aging. So some things that change in older adults is the visual accommodation, or the ability to focus on objects. They might be near or far. That decreases as age because they have decreased muscle tone in their eyeballs. They might have also a problem with their nearsightedness. Glaucoma, cataracts, macular degeneration are all conditions that decrease visual acuity. So nursing interventions that could help a client would be making sure the client, assisting them with regular eye exams and glasses that fit properly. A lot of times when patients are lower socioeconomic class, they forego that because it can be expensive. And so helping them find assistance to help pay for that can help them with that. Keeping their personal items within reach. If they're in the hospital, call light, make sure they know where it is. And you can always make sure that you are assessing their visual acuity. Do they see any safety hazards in their environment? And again, any change of environment can cause confusion. So helping a visually impaired client with a change of environment, explaining where everything is in the room, asking the client, do they usually use a clock? You know, you can say where you're at now. At 3 o'clock, there is a table. At 6 o'clock is the door. Things like that to help them know where everything is, and making sure that you are announcing yourself when you go into the room, and so they know that you're there. If they do have some vision left, that the lighting is good enough for them to be able to see. Let them know when you're leaving the room so they're not still talking. Don't rearrange their belongings without letting them know. Offer your arm for assistance when walking or being mobile, and offer any screen magnifiers. A lot of facilities have large print editions of books, magazines, or audiobooks that they might be able to use to keep themselves cognitively challenged as well. When we're talking about hearing, we know that people who are aging have hearing deficit, and we know they tend to lose range in the upper levels first. So when we're talking to them, we want to make sure that we are making our voice a little bit deeper, a little bit louder, but we don't have to shout at them. Are they wearing their hearing aids? Do they need help cleaning them or getting them in? Do they need new batteries? And you want to always be assessing their hearing. Is there a change from what was going on previously? And then, of course, make sure that they can see your face, they can see your lips when you're talking, and encourage any visitors to do the same. Changes in cognitive functioning. We see quite a bit of senescence, or what happens is the process of growing older and including forgetfulness or age-associated forgetfulness. There is a little bit of that, but it shouldn't be a lot. The elderly are capable of learning new things, although their speed of processing information is slower than it was in the past. We know that they have some disease processes that can change their cognitive functioning, such as dementia, any metabolic disorders that involve electrolytes or acid-base balance, stress, alcohol use, medication effects. Any vision or hearing impairments can cause change in cognitive functioning. Any depression. In fact, loneliness or social isolation can also cause change in functioning. When we talk about Alzheimer's disease, we think this is the leading cause of dementia in adults, and it's estimated that by 2050, about 14 million Americans will have Alzheimer's disease. We see a progressive loss of working memory, disorientation, and confusion, and what happens is there's a loss of neurons in the frontal lobes. The slide talks about stages of Alzheimer's disease. And so in early stage, we see recent memory loss, mild aphasia, meaning they can't always find their words correctly. They seek familiar routines and places and don't like to go to new places. They might have some difficulty, seem a little bit clumsy, difficulty with motor skills, have maybe mood where they care a little bit less or seem depressed, and they might need reminders to complete their ADLs and hygiene. In middle stage, we see a chronic to recent loss of memory, a moderate amount of aphasia where their sentences trail off or they can't remember what they were going to say. They may get lost, even in familiar places. They have repetitive motor movements with their fingers or arms, sometimes with their head and mouth. They might have some possible moodiness disturbances, and they might need a lot of reminders and help with their ADLs and hygiene. Then we have late stage of Alzheimer's disease, where it mixes up the past and present, where they maybe can't speak at all or speak very little. They are unable to know where they are or when they are in time. They have slow movements or no movements. They have many disturbances in mood and will need reminders with all ADLs. Risk factors of Alzheimer's disease would be increasing age, family history, female gender, Down syndrome, possible environmental or occupational therapy, environmental or occupational exposure to certain toxins, head trauma, or cerebral vascular disease. The best way for medical treatment is to prevent Alzheimer's disease, and so encouraging activity, good nutrition, being social. Slowing down the progression would mean that after early symptoms develop, the goal is to maintain the client at the highest possible level of functioning. There are some drugs that are approved for that, but we want to try to enable them to remain independent and living in their familiar home as much as possible. Then we treat symptoms by trying to improve memory. There is hope of slowing down progression, but that is not proven. And treating the secondary symptoms, behavioral symptoms such as insomnia or depression might be the next stage.